This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
So thanks for the organising committee for asking me to talk today. And I guess probably just wanted to start off today by saying my journey around patient deterioration in paediatrics commenced about 12 years ago. And at the time, I think I was handed the poison chalice because not only was I asked to implement one of the first nurse practitioner roles into a New South Wales ICU or any hospital in Australia, but I was also asked to fix the system in the ICU about how we responded to deteriorating patients. And it's really interesting to hear Kevin talk today because he talks about the scant evidence that's available and things that, but you know, when we started 12 years ago, it was so scant that it didn't exist. So I guess I'm going to take a little bit of a pragmatic approach today because really that's how when we were designing the system and I was involved in that, we had to really go about looking at what our current systems were, how we were able to develop that with the lack of research and evidence that was out there. So what I wanted to just talk a little bit about is the history and international experience, but very briefly because I know Kevin's done that, looking at the Australian adoption of that and looking at local escalation protocols. Because what I really want people to walk away with today, I know a lot of people would have well-developed systems within their organisations, but I constantly, one of the things that became really aware when I got involved with the Between the Flags program is that I actually had to take my tertiary centre egocentric hat off and realise that most paediatric patients are actually admitted to non-tertiary hospitals across Australia. And with that came, but then as soon as I go outside of the tertiary centre, all you hear is, oh my God, it's a paediatric patient, oh that's just terrible, and automatically before people even get to see the deteriorating paediatric patient, they've already got their guard up, they're already panicking, there's already this fear factor. So how do we now look at systems across all hospitals in New South Wales outside of the tertiary centres to make sure that people are arriving prepared and confident to be able to manage the clinical situation they're being invited in to manage? So again, this just highlights way back in 1998, we identified these problems. This is a paper that suggests, and certainly in adults, but it talks exactly about the failure of the organisation, the lack of knowledge, the failure to appreciate clinical urgency, the lack of supervision to seek advice. Now, we've put, this is what rapid response systems about. It doesn't necessarily help with the supervision in all cases, but it's certainly about trying to put some systems around this. This paper here, back in 2008 from the UK, identifies why children were dying. 26% had avoidable factors. And out of 126 of those patients had inadequate observations. So the evidence is there. It's telling us that we've got a problem. Garling inquiries in New South Wales public hospitals in 2008, and this was really based around the Sentinel event of a 16-year-old child that died in an adult hospital. And again, there was evidence there to suggest there was lack of observation and lack of supervision for that patient. So I think we know there's a problem. We no longer need to look for it. So if we think now about our early warning systems, we know that it's about creating conditions that allow bedside care to be summoned. We know that it's about bypassing the normal chain of commands. We've talked a lot about the last couple of days about mandatory crawling criteria. The reason we're mandating is that people feel confident to break down some of these traditional barriers that have been well embedded into our healthcare system. And we've certainly heard a lot about the afferent limb and the efferent limb. Again, this is the paper that Kevin had up. Again, in adults, it showed a 33% reduction in cardiac pulmonary arrest. There wasn't a significant change in adult mortality. Again, I've identified that for the two papers, there was a 21% reduction in mortality for those two papers, but as Kevin said, for the other two, it showed no difference. But the evidence is there that we know we've got to implement change. Heard lots about Standard 9, and I think there's a lot of ambivalence across everybody about how we're going to justify this, how we're going to do this, how we're going to look at what the systems are, what do the standards mean. But I think, again, as people that have got well-established systems, they're struggling with that. But I think for people that haven't got the so well-established systems, or you're just embarking on the journey, you can't allow this to put you off. You need to use this as a guide. You need to be able to start, and it's a starting framework. But people are getting really caught up on this, and I think one of the important documents that you probably need to read in consultation with Standard 9 is the National Consensus Statement, because this really helps you start to unpick some of the really practical components of what you need to do at a local level to be able to implement systems overall, and certainly looking at your paediatric response system. So I'm just going to talk a little bit about some of the bits I've purely looked around your team composition for rapid responses, because that's what I guess I really wanted to point out to people, that it's about, we get caught up in team, and, as Kevin said in the papers before, the team can be the RN, the physician, the pharmacist, a whole multitude of people. But for some people out in the rural sector, the team could be the FLEC-trained nurse and the ambulance service. So what constitutes team? We can't get so caught up in, you need to look at where you are, what your local resources are, and how you're going to use them. In the tertiary centres, we've heard people talk about the ICU is totally diluted at night because we don't have enough staff. So it's not, and that's because we have these big teams. But then we need to look about, again, our resources are different at night, how are we going to resource that across all levels of the health system? And that is really different depending on where you are, and you're not going to get extra money. We all know that, we've all realised that. So you need to think about what you're going to use and how you're going to use the staff you've got, and how you're going to educate them, and how you're going to support the system, so that inevitably we can reduce and support patients. So the questions we need to ask again is, who's on your team? What's that look like? Do you have a separate rapid response team for your arrest team? There's been lots of talking about people separating their systems. Again, you need to think about, if you've got your arrest team out in the middle of rural Australia, is the nurse and the ambulance team, well, it's going to be the same for your arrest as well as it is for your rapid response team. In your major tertiary hospital in the middle of Melbourne, if you've got 10 people on your arrest team, that's probably too many for most patients that deteriorate into the red zone, because you're going to get user fatigue. You're going to wear out your system. So you need to then think about what does that look like for you, and who's on your team. And then really what you need, then one of the things we need to look at is, what is the training and education that is required for that team? I know there's been a lot of sessions talking about that, and we need to think about, for the team, what's appropriate, what level, and what are we expecting them to do. We can't expect everyone on your team to have a master's level of education if you're a nurse, or, do we want to have a certificate, or is it about inbuilt training that goes into the systems we've already got? So how much of it's local, how much of it's in the university, and how much do we expect from people? And I think this is a big question that's being asked both from medical and from nursing, and we probably have got a bit of way to go with this, but we don't want to make it so complex and so complicated that we actually then can't actually resource the system again. So this is kind of a really important thing that we need to look at. And then when you've got your rapid response team, you need to then start saying, okay, these are the people we're going to have. Then you need to have your agreed timeframes. There's suggestions out there. There's in the literature. They've talked about it. But you need to think in your system, what is the realistic timeframe that we're going to be able to respond to this patient? Thinking about the competency in advanced life support. If you're a mixed facility, you need to be thinking, okay, we've got adult life support, but you need to have some level of training in place for your paediatric patient. How do we make those really experienced adult people that run out to the MET teams for their adult patients, do it with their eyes closed, confidently, to then getting a paediatric call and they all just buckle at the knees and start panicking and hyperventilating, and before they get there, they're automatically saying, well, this is just also different. When I think in reality, assessing a patient is pretty much the same across all patients. It's about identifying potentially what the diagnosis is. So thinking about, well, what are the therapeutic interventions that we need to do for that team? What is our provisional diagnosis? What do we need to do to keep that patient stable? How do we think about definitive care? We talked this morning, Sandy talked a little bit about the repatriation hospital. They were able to stabilise patients at the repatriation hospital. They've got to put them in an ambulance and move them. Yeah, it's only a kilometre up the road, but they've still got to have supports in place to be able to manage that patient in that acute situation, to be able to get them to definitive care, even though they're a fairly large organisation by scale. In the middle of, in the rural sector, that might mean that the ambulance team needs to come in, intubate the patient and support the patient until you've had the conversation with your retrieval service, which is a little bit different. Sometimes it's the Royal Flying Doctor service, other times it's your paediatric service. And then you need to think about who you can have on the phone. There's telehealth, there's telemedicine. These are all the things we need to be thinking about in the systems that we've got. That might be a totally unrealistic thing for you, telehealth, but you need to think about what you're going to do. And then the people around the team need to feel like they've got some level of authority to make that decision about who they're going to call and who's going to do the transfer and how that's going to happen. And there's mandated systems in most states, but it's not always as clear as we want. And I think that comes back to some of this work around standardisation of some of the processes that we need to do. And again, as we have heard lots about over the conferences, even in paediatrics, we need to think about how people are able to lead conversations in end-of-life care. You've got a sick paediatric patient that may not have a life-limiting illness before they present to your hospital, but knowing that you're 500 kilometres away from a major tertiary hospital, you need to be really open and honest with families about what's happening for that patient. What does this mean, and having those conversations. And sometimes that is saying that your child may die as a result of this, depending on what happens. So it's about having and being open and honest with families around this. You need to think about how you're going to escalate to the treating medical officer. So obviously there's going to be, and that, again, that's variable between the paediatrician, between the GP VMO, between the locum that's come into your town for the weekend. So again, you need to think about at every given point in time where the escalation needs to go to. Communication, everyone's talked a bit about that today, that you're able to communicate the relevant information, the appropriate information in a concise way so that you can escalate care accordingly. How that care is going to be documented across all systems. The documentation around rapid responses or acute care situations is varied and vast, but in general I think it's often generally poor, and it's hard to pick out of the documentation what that actually meant for that patient. In New South Wales, we've got a standardised system now of how that's documented. But again, I think when we were able to look at literature, having one way that we're documenting the same way, that then you get this wealth of data that we can actually start asking questions of and interrogating so that we can make systems improvements. Again, education at a local level. You've got a paediatric patient, you've got your paediatric expertise. How do you educate the staff? How do you make them feel confident? How do you make them feel that they did the right thing, they called, and that appropriate care has occurred? And obviously all of this support then goes on to look at how you can provide ongoing quality improvement around your processes, particularly around, if you're looking specifically at paediatrics, how you can improve your response to deteriorating paediatric patients in your organisations. So when you look at your paediatric emergency system, one of the things when working with Between the Flags and certainly working with the CEC we looked at is that most hospitals outside of the tertiary centres said, okay, we're responding to paediatric patients, and they aligned it with the adult SIRS protocol. And maybe, if you're lucky, there was this little suggestion, if it's a paediatric patient, do this. Most systems actually weren't developed enough to even really factor the paediatric patient into it. So it was just this thing that everyone, again, just was nervous about. They knew it was there, but they didn't have it really clearly coordinated or communicated within their organisations of how they were going to do that. So it's really important that that needs to happen. What is your paediatric cover? Is it adequate for, if you're admitting paediatric patients, what does that look like? Again, sometimes it will be 24-hour cover, other times it won't be, but how are you going to summon that help 24 hours a day? You know that your escalation needs to be easily readable, easily for the staff to navigate, and look at your switchboard. And when I go through some of the examples next, you'll understand that if it's a paediatric patient, you're putting out your MET call, but because it's paediatrics, there might be additional people that the switchboard need to summon for you that aren't on the paging system. They might need to call the paediatrician and so forth at home. So really. And I think this probably goes across all of the sort of outliers in your system. This is just an example of a paediatric emergency response escalation for a major tertiary adult hospital in Sydney. And I guess what you can see here is, if we've got the three coloured, but what you can see here in the red zone over here is that they've summoned their normal activation of how they would respond to an adult in their organisation, but plus the paediatric person that's covering that for that patient. So that paediatric expertise arrives, it's clearly documented, everybody knows that's what's going to happen, and then it's about, if the condition deteriorates still, it's escalating them to go into their code blue, so they've got their bigger team, the anaesthetist is coming. So it's really clear for staff and that organisation, which is really important. The executives have signed up to this, the hospital signed up to this, they know exactly how they're going to manage their paediatric deterioration. This one here is for a metropolitan hospital in Sydney, not a tertiary referral centre. Again, similar thing. It says you're going to activate your rapid response, but it's going to have paediatric. what you're going to have there is that you get the paediatric registrar who's coming. This hospital also has 24-hour paediatric. It doesn't have 24-hour. I think it's till midnight, but certainly the paediatric person is going to be contacted at home to be able to help them respond to that paediatric emergency. Again, at the top, it clearly says this is your paediatric emergency escalation plan. This one here is for a base rural hospital in New South Wales. These are all New South Wales example because obviously that's where I'm from. But what it says here is that they're going to initiate their local response. Okay, they're going to do that. But what's going to happen is the switchboard is going to immediately call the paediatrician on call for that day and that night. So it's automatically, as part of that response, that paediatrician is being called. And also here we can look that it's also asking them to call NETS, so NETS being the retrieval service for paediatrics. Not only does NETS retrieve, they'll also be able to be on the end of the phone to be able to help coordinate the care around that patient and be able to work with the team locally to deliver the best care for that patient in that clinical situation. And just the final example I've got here of escalation. This is for a small district hospital. Again, it doesn't admit paediatric patients. Paediatric patients will still present. So this is more looking at their emergency department. What it says here is they're going to initiate their call. Their local team's going to respond, but the GP VMO is going to be contacted for that patient. It's a paediatric emergency. The GP VMO needs to be aware to come in and help support that system, also telling them to call NETS. Okay. This might seem really simple stuff, but this is quite a difficult process to go through for organisations because it's actually starting to ask the hard questions about the resources you've got available, asking about what training and level of facility and support you've got for paediatric patients. And I guess it's something they have to go through for all levels of all different types of patients that are presenting outside of their normal adult patients. This is the local, and I guess this is just me trying to have a talk about how you can have different systems for different level organisations. This is the SIRS protocol for the Children's Hospital at Westmead, obviously where I work, and what we've got here is we've gone for, again, the two-tiered rapid response system. So we have a rapid response system for patients in the red zone, and we've still got our what we don't call it a code blue, so we've still got our arrest system here. I guess one of the things I wanted to talk a little bit about is our team composition. Again, we're a major tertiary centre, and we've got a fairly small rapid response team. So we ask the question, if the patient's not in imminent arrest, what we call our rapid response team, in hours of 7:30 to midnight, the ICU response to that is a nurse practitioner from the intensive care unit and the treating team registrar. So they're the two people that respond to that patient's clinical deterioration. And we obviously went around a small team. Being paediatrics, we have a large number of activations, but we also thought we again wanted to look at how we could get the specialised skills required to be there for that patient. Out of hours, then we go to the more traditional model of having the ICU registrar and a PICU nurse. However, the access to the PICU registrar after hours is becoming increasingly limited. We're beyond capacity, so we're often unable to send our ICU registrar to those emergencies. So after hours, we've implemented as a hospital an advanced trainee that's roaming the wards for that clinical reason. So the ICU isn't as overburdened. And obviously then when we, being a big centre and we have our what people are calling their code blues, we have a much bigger team. So we've gone from the outreach team, we send a nurse practitioner and our medical person from the ICU for that, a ward registrar, the anaesthetist, the after hours nurse manager, the social worker, the porter. We get that big team. But if we have 2,000 activations a year. If we activated that team 2,000 times a year, the system would just fall over and it'd be unsustainable. So again, really thinking about what's required, where you work, what does that look like. So just in summary, I think we're in a stage now. It's exciting. I've been coming to these conferences now for the last 5 years and just listening to what's happening. I think the evidence is scarce, but it's there. I think we're in a process now where we have to act. I think it's sometimes a little overwhelming when you come to these conferences and you listen to these people doing fantastic research and really getting into looking at their systems. But not everyone has to do that to be able to implement a successful system in your organisation. And we can't be too disturbed by, there's enough evidence there to say we have to do it. Every clinician has the ability to go and ask the questions of their own facility. You know where you work best. You can ask the hard questions locally and then come up with some robust systems and implement them so that you can manage patients. I think it's no longer required that you have to keep going back to find out, do we have a problem? Well, we know this is the system we need to work for. I think Australia has taken a lead role in the national approach to implementation. We've still got a long way to go as far as standardisation of outcome data, and I think that is where we need to work really hard about what are the outcomes for patients and how can we improve care. And I think overall, as long as your escalation protocol, particularly looking at all patients, but again, I'll plug the paediatric component, you really need to think about what resources you've got available, that you've got a consistent service to be able to respond to those patients 24 hours a day if they're presenting to your facility 24 hours a day. And, it needs to be, client-specific if you're around paediatrics. If you've got obstetrics, we've heard, they've got specific programs, and I think that's the next phase of where we're heading with this work.